Hello, Dr. Hamid is here. In previous lecture, we talked about the neurotransmission of the cholinergic fiber. We'll continue the lecture, and in this lecture, we'll talk about the cholinergic agonist. As I explained, cholinergic agonists are the drugs which can increase the effect of acetylcholine in the cholinergic fibers. They have different mechanism of action, and on the basis of their mechanism of action, we can classify cholinergic agonists into two groups. The first group is direct cholinergic agonist, and the second group is indirect cholinergic agonist. Indirect cholinergic agonist. Let me explain the mechanism of action of each group. Direct cholinergic agonists, they have same structure as acetylcholine, and they can mimic the acetylcholine effect. It means that they can bind to the cholinergic receptor, and by binding to the cholinergic receptor, they are able to activate the receptor, and they are able to show the internal efficacy, or they can activate the signaling molecule inside the cell, or they can cause the polarization of the adjacent neuron. This is the mechanism of action of direct cholinergic agonist. Again, I will repeat, they have same structure as acetylcholine. They can bind to the cholinergic receptor, they can activate the cholinergic receptor. It means that they can mimic the acetylcholine actions. The second is indirect cholinergic agonist. Do you remember we talked about one enzyme, acetylcholine esterase, which can cleave the acetylcholine to choline and acetate. It means that it can terminate the action of acetylcholine. Now I will draw one presynaptic neuron and postsynaptic neuron. When we release acetylcholine into the synapses, we had one enzyme, as you remember I have drawn like this. This enzyme is acetylcholine esterase, and it can cleave acetylcholine, and it will convert acetylcholine to choline and acetate. It means that it can terminate the action of acetylcholine. Now imagine that we inhibit this enzyme. By inhibition of this enzyme, it means that if we use some chemicals, or if we use some drugs which can bind to the active site of this enzyme, occupies the active site of this enzyme, then this enzyme is not able to bind to acetylcholine and is not able to cleave the acetylcholine. Then what will happen to the concentration of acetylcholine? The concentration of acetylcholine in the synapses will increases. More acetylcholine will bind to the cholinergic receptor, and more effect of acetylcholine we can see. This is the mechanism of action of indirect cholinergic agonist. So direct cholinergic agonists, they directly bind to the receptor and they can increase the effect of acetylcholine. Indirect cholinergic agonists, they inhibit the acetylcholine esterase enzyme. By inhibiting the acetylcholine esterase enzyme, they can inhibit or they can prevent cleaving of acetylcholine. The level of the acetylcholine, concentration of the acetylcholine in the synapses will increases. More acetylcholine effect we can see in the cholinergic fibers. Okay, first we'll talk about the direct cholinergic agonist. We can classify direct cholinergic agonists on the basis of their chemical structure. We can classify them into two groups. The first groups are esters, and the second groups are natural alkaloid. Natural alkaloid. In the first group, which are esters, we have three chemicals. You can remember these three chemicals as A, B, C. A is for acetylcholine, B is for Betanicold, and C is for carbachol. These are the three esters which we have, which they can directly bind to the acetylcholine receptor, and they can activate the acetylcholine receptors. First, we'll talk about the acetylcholine. Acetylcholine itself, it's a direct cholinergic agonist. It has some effect on cholinergic receptors. All you know that we have two types of cholinergic receptor. The first type was muscarinic, the second type was nicotinic. This acetylcholine, it has ability to bind to both type of receptor, and it has ability to show the both type of receptor effect. So acetylcholine, it has nicotinic as well as it has muscarinic effect. Nicotinic and muscarinic effect. It means that when it binds to nicotinic receptors, which are located in the ganglion, which are located in the adrenal medulla, which are located in the neuromuscular junction, it can show nicotinic effect. When it binds to the muscarinic receptors, it can show muscarinic effect. Acetylcholine is a quaternary amine. And all we know that this quaternary amine, they cannot cross the blood-brain barrier, they cannot cross the cell membrane. Another characteristic of acetylcholine are their actions. Its actions. It has effect on cardiovascular system. It shows some action on GI. It shows some action on bladder. It shows some action on the eye. When it binds to M2 receptor, we have M2 receptor on cardiovascular system. When it binds to the M2 receptor, it can stimulate the M2 receptor, and by stimulating the M2 receptor, all we know now, M2 receptor is a type of inhibitory receptor. It will activate GI protein, and GI protein will inhibit adenylate cyclase. Cyclic AMP, which is second messenger, will decreases inside the cell, and that will inhibit the cell. And this M2 receptor on cardiovascular system it has additional mechanism of action. When we activate M2 receptor on cardiovascular system, it will opens the potassium channel. This M2 receptor, it will opens the potassium channel. More potassium channel will be in the cardiac cells, and that will cause hyperpolarization of cardiac cells, and it will inhibit the cardiac cells. By inhibiting the cardiac cells, first of all, heart rate will decreases, cardiac output will decreases, force of contraction will decreases. So the action of acetylcholine on cardiovascular system, heart rate decreases, cardiac output decreases, and force of contraction will decreases also. It means that it will inhibit the heart. But on the vessels, this acetylcholine, it can increase nitric oxide production, and by increasing the nitric oxide production, it can cause vasodilatation. This is another mechanism how acetylcholine can decreases the blood pressure. So another effect which acetylcholine has, nitric oxide production will increases, and it will cause vasodilatation. And this vasodilatation will decrease the heart rate. It will decrease the heart rate. This was about the action of acetylcholine in cardiovascular system. The next system is GI system. We know that we have M1 receptor in the stomach. When acetylcholine binds to M1 receptor, the movement in the digestive system or in the stomach will increases, the motility will increases, as well as the secretion will increases. HCl secretion will increases. So on GI, we have M1 receptor. It will increase the motility, and also it will increase the secretion. On the bladder, we have M3 receptors. When acetylcholine binds to the M3 receptor, it will increase the contraction of the detrusor muscle. And increase in the contraction of the detrusor muscle, it will cause urination. So it will increase contraction of the detrusor muscle. This will lead to urination. It means that acetylcholine can increase urination. What about eye? We have muscarinic receptor in the eye also. When acetylcholine binds to the muscarinic receptor in the eye, it will cause miosis. And also, it will decrease the IOP, intraocular pressure. Because of that, we can use this cholinergic agonist for treatment of glaucoma. This was about acetylcholine. But the problem for acetylcholine is, do you remember we said that we have acetylcholine esterase? This has two subtypes. One is true, another one is false. True subtype is specific for acetylcholine. It can cleave the acetylcholine and it will terminate the action of acetylcholine in seconds. It means that when we apply this drug to the patient, or when we give this drug to the patient, the duration of action of this drug is short. Because of that, we are not using this drug for treatment of diseases or in clinics. Another problem with this drug is that this drug shows nicotinic as well as muscarinic effect. The effect for this drug, the action of this drug is non-specific. Because of that, we cannot use this drug in the clinic. So two important things is there. One is short duration of action. It has short duration of action. And second is non-specific action. Non-specific action. Because of these two reasons, we are not using acetylcholine as a drug in the clinic. The second drug is Betanicold. Betanicold is a carbamic acid drug. Carbamic acid ester. Because of this carbamic acid, this acetylcholine esterase is not able to cleave the Betanicold. So the duration of action of Betanicold will increase. In the chemical structure of Betanicold, we have a methyl group, and because of this methyl group, Betanicold only shows muscarinic effect. So the second characteristic of Betanicold, it has only muscarinic effect. It lacks nicotinic effect. Only muscarinic effect. It lacks the nicotinic effect. You can remember the indication of Betanicold. It starts with B. It means that we only can give this Betanicold for the problems or for the diseases in the bladder. Okay, now we explained about the acetylcholine. We said that acetylcholine can bind to M3 receptor. It can increase contraction of the detrusor muscle and it can cause urination. Also, this one can bind to muscarinic receptor in the gastrointestinal system and it can increase the motility and secretion. Betanicold also can bind to the same receptors, and by binding to the same receptor, we can give in some diseases. For example, imagine that there is atony. Atony means when the tone of the muscle is not present, or muscles don't have tone. For example, imagine that if this detrusor muscle, there is no tone in the detrusor muscle, there is no contraction in the detrusor muscle, or there is less contraction in the detrusor muscle, patient will have problems in urination. Now, for treatment of this atony, we have to increase the contraction, we have to increase the tone. How we can increase? By giving some drugs which can bind to the M3 receptor and they can increase the contraction of the detrusor muscle. Betanicold is one of those drugs. Betanicold can bind to the M3 receptor on the bladder and it can increase the contraction of the detrusor muscle. So indication for Betanicold, indication for Betanicold. We can give for post-operative atony, postpartum atony, and we can give this drug for treatment of megacolon. These are the indication for Betanicold. But this Betanicold, if it binds to M2 receptor in cardiovascular system, it can decrease the heart rate, it can decrease the cardiac output, and it can decrease the force of contraction. This can be adverse effect of Betanicold, which you should remember. Okay, if any adverse effect occurs with using of Betanicold, the antidote for that is atropine sulfate. What is the antidote for Betanicold? Atropine sulfate is antidote for Betanicold. The third drug, which is in the ester group, is carbachol. Carbachol has two effects. It can, like acetylcholine, it can show nicotinic effect, and it can show muscarinic effect. It means that carbachol can bind to both type of receptor, muscarinic as well as nicotinic. From this, we can find that carbachol has non-specific effect like acetylcholine. This is one of the drawbacks of carbachol, non-specific effect. Carbachol, you can remember C of the carbachol as cardiac indication. Cardiac indication. You can give this carbachol for its cardiac indication. It means that it can bind to the M2 receptor, it can opens the potassium channel, and it can decrease heart rate, decrease cardiac output, and decrease force of contraction. But because of some problems, the first problem was these non-specific effect. The second problem for carbachol is that it is high potential. It has high potential effect. First, it is non-specific. Second, high potential effect. Because of these drawbacks, we do not use carbachol for treatment of cardiac diseases. The only indication for carbachol is it has shown that it can bind to the muscarinic receptors on the eye, and it can decrease the IOP. Because of that, we can use it for treatment of glaucoma. The only indication nowadays for carbachol is for treatment of glaucoma. This was about the esters direct cholinergic agonist. Another important point which I have to tell you is that I told you that carbachol can bind to nicotinic acid, a nicotinic receptor. We have this receptor on the adrenal medulla. When it stimulates this receptor on the adrenal medulla, carbachol can increase norepinephrine and epinephrine release. It increases norepinephrine and epinephrine release or secretion. This was about carbachol. In natural alkaloid, which is another group of direct cholinergic agonists, we have two chemicals. One is nicotine. Natural alkaloid starts with N, so N, one of the chemical is nicotine. Another chemical is pilocarpine. We'll not talk about nicotine in this lecture because nicotine it's a drug which it can show anticholinergic effect. We'll talk about nicotine in anticholinergic lecture, but we will talk about pilocarpine and characteristic of pilocarpine. Pilocarpine is a drug which is tertiary amine. Tertiary amine. When I'm saying tertiary amine, it means that it can cross blood-brain barrier, the absorption is fast, and also the termination of action is also fast, elimination is also fast, duration of action is also short, it has short duration of action. It is stable to this enzyme, acetylcholine esterase. Acetylcholine esterase. Okay, this pilocarpine, it has shown that it can decrease the IOP or intraocular pressure by opening the trabecular network. And it will open the trabecular network, it will increase the outflow of aqueous humor, and it has shown that it can decrease the IOP by this mechanism. So one of the characteristics of this drug, it opens the trabecular network, and by opening it decreases the IOP. The second characteristic of pilocarpine, it is a potent, or it is a strong stimulator of secretion. It will increase the secretion of saliva, and it increases the secretion of lacrimal gland. It means that it increases salivation and lacrimation. Indication for this drug, what are the indications for this drug? If it decreases the IOP, so we can use it for treatment of glaucoma. And what about for these secretions? We have autoimmune disease, which we name it Sjogren disease, Sjogren syndrome. In this syndrome, salivation and lacrimation decreases because of production of some antibodies which will attack on the salivary gland as well as lacrimal gland, and it will destroy those glands, and salivation and lacrimation decreases. Now this drug, I mean pilocarpine, it binds to the muscarinic receptor which are in the salivary gland and lacrimal gland, and it can increase the salivation and lacrimation. Another indication for this drug is when there is xerostomia due to radiation of neck and head, we can use pilocarpine to increase the salivation, and we can treat the xerostomia. This was about direct cholinergic agonist. So on the basis of the chemical structure, we can classify direct cholinergic agonist into esters and natural alkaloid. In ester group we have acetylcholine, betanicold, and carbachol. In natural alkaloid we have nicotine and pilocarpine. The second group of cholinergic agonist is indirect cholinergic agonist. I explained the mechanism of action of indirect cholinergic agonist. They inhibit acetylcholine esterase. By inhibiting this enzyme, they can inhibit or they can decrease cleavage of acetylcholine. Concentration of acetylcholine in the synapses increases, and that will increase the effect of acetylcholine to the adjacent or neighboring neurons or to the target tissue. Now, we have some chemicals which can inhibit this enzyme reversibly. They bind covalently to the acetylcholine esterase, and by binding to this enzyme, they can reversibly inhibit this enzyme. And those are reversible acetylcholine inhibitor. Reversible acetylcholine esterase inhibitor. But we have some other chemicals also which can bind to this enzyme non-covalently, and they can inhibit this enzyme for long duration of time or forever. So if we want to see the effect of this enzyme again, we have to regenerate this enzyme. Those drugs are irreversible acetylcholine esterase inhibitor. Acetylcholine esterase inhibitors. So on the basis of type of bonding which these chemicals can make with acetylcholine esterase, we classify these drugs, this group of drug, into two groups. One is reversible, another one is irreversible. First, we'll talk about the reversible acetylcholine esterase inhibitor. In this group, we have chemicals like pyridostigmine, neostigmine, edrophonium, we have pyridostigmine. Before talking about the characteristic of each drug, on the basis of the duration of action, we can classify reversible acetylcholine esterase into two groups. One is short action or short acting reversible drugs. Another one is intermediate acting reversible acetylcholine esterase inhibitor. The short acting, usually the duration of action for these drug, I will explain about it, it's 10 to 20 minutes. But for intermediate acting, the duration of action is from 30 minutes to 2 hours. This was about the classification of reversible acetylcholine esterase inhibitor. Now we'll talk about each drug. Edrophonium is a type of short-acting drug. It's a type of short-acting because it has rapid elimination. It has fast absorption also, and we can use this drug. We can write the indication of this drug. We can use this drug for different indication. The first is for diagnosis of Mycenia gravis. Mycenia gravis. What is Mycenia gravis? Mycenia gravis is an autoimmune disease which we make antibodies against the cholinergic receptor, especially the nicotinic receptor in the neuromuscular junction. This antibody will attack the nicotinic receptor, or it will occupy the nicotinic receptor. Now, how we can diagnose? By giving edrophonium. Edrophonium will inhibit this enzyme. The level of acetylcholine in the synapses increases. When the level of acetylcholine in the synapses increases, it will improve the signs and symptoms of Mycenia gravis. This is one of the indications. The second indication is if we want to differentiate between cholinergic crisis with myasthenic crisis, we can use these edrophonium. This is another indication of edrophonium. The third indication for edrophonium is to reverse neuromuscular blockers. We give these neuromuscular blockers before anesthesia to facilitate intubation during the surgery. These neuromuscular blockers, they will block the acetylcholine esterase competitively. Now, when surgery finishes, we should terminate the action of neuromuscular blockers. One of the aim which we can do, or one of the strategy we can do to terminate the action of these drugs, we should increase the concentration of acetylcholine in the synapses. These acetylcholine will remove the neuromuscular blockers from receptor, and they will occupy the receptor. Then the contraction of the muscle will increase. Now, by giving this ecotiophate, this edrophonium will increase will inhibit this enzyme. It will increase the concentration of acetylcholine, and it will reverse the neuromuscular blockers effect. This was about indication of edrophonium. 3 other drugs we have in this class also. In reversible acetylcholinesterase inhibitor. These 3 are intermediate acting drugs. All are intermediate acting drugs. First, we'll start talking about physostigmine. Physostigmine is a tertiary amine. It's a tertiary amine. It can cross the blood-brain barrier. It can cross the cell membrane easily. Absorption is fast. The duration of action for this drug, it's between 30 minutes to 2 hours. And the main indication for this drug to increase the contraction of gastrointestinal as well as bladder muscles. So the first indication is increased contraction of GI and urinary muscles. As well as we can give this drug as an antidote for atropine. Antidote for atropine. Atropine is a anticholinergic drug. It means that atropine can block the cholinergic receptor. Now, if there is toxicity with atropine, this drug, physostigmine, it can remove atropine from receptors, and by removing it, it will manage the toxicity of atropine. The second drug from intermediate acting is neostigmine. Neostigmine is a quaternary amine. This neostigmine, indication for this neostigmine, we can use neostigmine for treatment of myasthenia gravis, as well as we can give neostigmine to reverse neuromuscular blocker. It means that we can give it as antidote for neuromuscular blocker. These are the indication of myasthenia gravis. Last is pyridostigmine, and another drug is there also, ambenonium. These 2 drugs, they have long duration of action. So we can give these 2 drugs for treatment of chronic myasthenia gravis. Chronic myasthenia gravis. This was about the reversible acetylcholinesterase. Another group of drug which we have is irreversible acetylcholinesterase inhibitor. As I explained, they can inhibit this enzyme irreversibly. They make covalent bond with acetylcholinesterase, and they can inhibit the acetylcholinesterase irreversibly. Now, we do not use drugs for treatment of any diseases except one drug, that is ecotiophate. We can use this drug for treatment of glaucoma. It decreases the IOP, and we can give this drug for treatment of glaucoma. Some other chemicals we have in this group, some insecticides are there. For example, malathion and parathion. These are the insecticide. And Some warfare chemicals are there also. For example, sarin is a warfare chemical which they can inhibit this enzyme irreversibly. What will happen if there is toxicity with this insecticide or it is toxicity with this warfare? You can remember these signs and symptoms of toxicity with these words only: dumbless. Dumbless. What are the signs and symptoms? D is for diarrhea. Diarrhea. U is for urination. M is for meiosis. B is for bronchoconstriction and bradycardia. Bradycardia and bronchoconstriction. L is for lacrimation. E is for excitation. Double S, one of the S is for sweating, and another one is for salivation. These are the signs and symptoms of toxicity with irreversible acetylcholine esterase inhibitor. Now, what is the treatment for this toxicity? How we can treat it? How we can manage it? We can give some of the chemicals, some of the drugs which can dissociate these chemicals from this enzyme. Can remove the irreversible drugs from the acetylcholine esterase, and by removing these chemicals, it can reactivate the enzyme again. Because of that, we are saying that those are enzyme reactivator. Like I can write it here. If toxicity occurs, the antidote. The first antidote is enzyme reactivator. Enzyme reactivators like pyridoxine. This is one of the drug which we can use for treatment of toxicity. The second drug which we can use is atropine. And if there is convulsion, we can use benzodiazepine for treatment of convulsion. Benzodiazepine. Okay, this was about today's lecture. We talked about cholinergic agonists. We classified cholinergic agonists into direct and indirect. We classified direct into esters and natural alkaloid, and indirect we classified them into reversible inhibitors and irreversible inhibitors. In next lecture, we'll talk about the anticholinergic agonist.